The broadcast is now starting. All attendees are in listen-only mode.
Well, good morning or good afternoon, everyone. Thank you for joining me today for our Home Health Top Claim Errors session. My name is Krista Shipman. I am part of the Outreach and Education team with National Government Services, and I will be your hostess for our call today. I'm noticing that our closed captioning isn't working, so give me just a second. I'm going to fix that, hopefully. Let's see. Okay, there we go. That should be working now. Yes, awesome. Okay, so as I said, this is the Home Health Top Claim Error session, and I am Krista Shipman, part of the Outreach and Education team with National Government Services. And I have just a few slides to go over, kind of some disclaimer slides and talking about what our presentation is going to be all about before we really get started. So, oh, I see it says slow connection. Hopefully my slides will be moving for you okay, because yeah, I've been having internet issues today. So hopefully we're not going to have too many issues. But what you see on your next slide is our disclaimer. This is basically saying that the information that is being presented today is accurate and up to date as of today. And so, as you may know, Medicare does have a way of changing. And so it is the responsibility of every provider to remain up to date on all of the current guidelines and regulations, which can be found on CMS's website. As another reminder, there's no recording permitted during our session today, so no audio recording or digital recording or any other type of recording that applies to any session that is hosted and presented by National Government Services. So our agenda for today, why we're here today, is just to talk about the errors that we have seen on home health claims over the past quarter. So we're going to start out by talking about some billing reminders, because it might be helpful just to kind of go back to basics and see, that we remember that what like the general guidelines are for billing home health, the notice of admission and the claims. So then we're going to get into actually looking at the top rejection reason codes and the top return to provider codes, or RTP codes, that have been assigned in the past quarter, so the past 3 months. And then we'll get into some resources, some of which you may have seen during the rolling slides before we started today. So we'll just touch on some of those, and then I will open up for your questions. So we have an hour today. We may not need all of that time. The majority of the time, half an hour or so, I'll be going over the slides, and then I will open up for your questions. So let's get into it. So some reminders about billing. So the notice of admission, the purpose of this is to open up an admission period. And when the admission period is opened, all providers, including other home health providers, are able to see, based on the information in the common working file, that a home health admission period has been open. And so that allows providers to either adhere to the transfer process, or for providers outside of home health, know that if a patient is in a home health admission, then consolidated billing rules apply. And the notice of admission should be submitted within 5 calendar days from the start of care. It's on a 3-2A bill type, and it's ready to be submitted when the physician's orders containing services required for the initial visit have been received, and the initial visit has been conducted and the patient's been admitted to home health care. So that's the first billing that's going to be submitted. And then we have our claims that will be submitted as part of that admission period. And claims should be submitted after all of the services have been provided to the patient within that billing period. The physician has to have signed all orders and the plan of care. The face-to-face encounter has to have been completed. The OASIS should have been submitted and accepted by IKEYS. And any warnings that you may see when you submit to IKEYS, regardless of whether or not the OASIS has been accepted, should be investigated and corrected just to make sure that everything is set and ready to go when you submit that claim. And the claim is submitted either at the end of the 30-day period or when the patient has been discharged. So if they're discharged before the end of the period because they've met their goals under the plan of care, it can be submitted then. You don't have to wait until the end of the 30 days. Or it can be submitted when the patient transfers to another home health agency. And the claim is submitted on a 329 type of bill for the initial submission. If there's a claim that's been submitted and it needs corrections, like maybe there's information about services or visits that weren't included initially and they need to be added, then the claim can be adjusted, and that's a 327 type of bill. Every claim has to contain a 0023 revenue code, and the line that contains that revenue code has to be billed with a group or produced HIPS code or any valid HIPS under the patient-driven groupings model, or PDGM. All of the services that were provided to the patient, whether they're covered or non-covered, need to be included on the claim, and those include services that are provided directly by the home health agency or under arrangements with the home health agency. There also has to be a site of service code on the claim. And as far as when the claim should be submitted, depending on whether you have all the information that's in their medical records and set to go in order to submit the claim, anytime within 1 calendar year of the period end date would be considered timely filing for a claim. So we're going to look at, as I said, the claims that didn't fully process because of either being rejected or returned within the past quarter or the past 3 months. So rejections are those that you will see in status location RB9997. And most of the time, those claims need to be resubmitted. There's only certain situations that a claim would need to be adjusted once it's rejected. And then there's those that are RTP, the TB9997 status location. And those are typically the easier claims to correct because you can go into the system, you can go into FIS-DDE, or if you use some other type of software to submit claims, you can go into that system, figure out why the claim has returned and correct those certain fields or errors and then resubmit. So first, we're going to talk about the rejections. And again, these are those that typically need to be resubmitted once they've hit a rejection error code. So you can see here the top 5 rejections for the J6 jurisdiction 6 within the past 3 months. So again, we're looking at April, May, and June of this year. So we have our top reason code 37364 with 934 claims, 38055 with 895, 38200 with 680 claims, 39929 with 411, and U5211 with 354. And then in JK, you see a lot of the same ones, just either ordered differently, or I believe there's one here that wasn't in J6. But just know that all of the ones that we're going over are in both regions in the top 10. We're just looking at the top 5. But here we have 39934 at 551 claims, 38055 with 162, 37364 with 125, 39929 with 86, and 38200 with 65 claims that hit that RTP in this quarter's worth of time. So we're going to look at what the reason code narrative is for the reason code, and then we're going to kind of interpret that. So the reason code narrative says that the dates of service fall within a span of days between the NOA and the from date on a claim type of bill. The statement from date is on or after January 1st, 2022, which is when the NOAs were implemented that needed to be submitted, and the NOA is 30 days or more from the from date, and so the payment amount is 0. So basically, it's a late NOA, and it was so late that the first claim, or the claim that applies to it, is in the system within the 30 days of the NOA, if that makes sense. I think I just confused myself as I was talking through that. But the rundown is that this applies when the receipt date of the NOA is more than 30 days out from the start date of admission. And so then the claims from date falls within that period of 30 days, which would cause 0 payment. Now, if the NOA was late due to a billing error, meaning the provider or the home health agency's own error that the rejection with 0 payment is correct. If the NOA was late due to a system error, then a late penalty exception request can be submitted on the claim. Our next reason code, 38055 or 38055, the narrative says that the home health claim was submitted as a Medicare primary claim, and it has the exact dates of service to a previously submitted claim for the same provider with at least one matching revenue code. Basically, it's a duplicate to a claim that's already been submitted or already in the claims processing system. So I mentioned earlier that if there were services or maybe billing or payments were submitted wrong, not payments, oh my goodness, the cost of services was submitted incorrectly. If there was just any type of error on the initial claim that needs to be corrected, then you can submit an adjustment. You don't submit a brand new claim in order to kind of capture those services or like line items that weren't initially reported on the claim, because all of the services provided to a patient within that home health billing period have to be submitted on one claim. So just as a way to kind of try to avoid this is just to verify what's been billed and what's already processed in the claims processing system before submitting anything new to Medicare, any type of new billing, and that helps to avoid any overlaps of your own claims. The next reason code, 38200, it's basically the same thing, just worded a little bit differently. It says the claim is an exact duplicate of a previous submitted claim where the following fields on the history and processing claim are the same. And so it's the same beneficiary, same provider, same dates of service. So it looks at all of that. But again, it's overlapping your own claims. So just worded a little differently, FIS is only going to accept, and FIS being the Fiscal Intermediary Standard System, which is a claims processing system, is only going to accept one original bill for each period of care. And so if there's a claim that's already in the system that's processed, then anything that contains that same information is going to reject as a duplicate. So again, just try to verify what's already submitted, either by checking your remittance advice or NGS Connects or looking in FIS CDE to see what's out there and processed before submitting anything new. And then the reason code narratives for 39934 and 39939 are very similar. So as you can see, like 39934 says all revenue claims or all revenue lines on the claim are denied as non-covered. One or more denotes beneficiary liability, and then 39929 says that each line of charges has been rejected and or rejected and denied. Basically what this is saying is that you have to look at the line item details in order to figure out why the claim received this overall claim edit. So both of these reason codes are pointing you to looking at line item details. So in order to look at line item details, if you're looking in FIS-DDE, you have to go to map 171D, which the way to get there is from claim page 2, you either hit F2 once or F11 twice. I think it's claim page 2. It's either claim page 2 or claim page 3. Wherever your line item details are, you go out a little bit further in order to see that information. Or if you're using NGS Connects, you can hover over a reason code in the line item details, and that will pop up what the reason code says. So kind of two different ways of getting there. Okay, the next rejection or reason code is U5211, and this is saying that the statement from or through date is greater than the date of death on the patient's record, or what CWF has as the patient's date of death. And so the billing guideline behind this is that the period of care cannot go past a patient's date of death. So your discharge date or your through date or your to date must be either on the patient's date of death or before the patient's date of death. It just cannot be after, which is when that reason code is assigned. So you want to look at the patient's, what the patient's record says based on what the date of death is on file and the dates of service that you're billing. If you need just to correct your claim in order to correct your through date or your to date, you just need to correct that and submit a new claim. Or if it's a returned claim, because sometimes some of these reason codes will show as RTPs and rejections. So depending on which one, if it's a rejection, you have to resubmit. If it's an RTP, you can correct and resubmit. Now, if the actual date of death was reported in error, then the Social Security office has to correct that. The Medicare Administrative Contractor, which is us, National Government Services, we can't correct that. So Social Security has to be contacted in order to correct the date. If the patient is still alive and the date of death was reported out there in error, then the patient or their representative has to contact Social Security in order to get that corrected. And again, that cannot be corrected through us. That has to be through the Social Security office. Okay. I went through those kind of quickly. Hopefully we hit all of the main points there, but let's get into now the top RTP reason codes, or return to provider reason codes. So we're starting again with J6, and these are the top 5 RTPs from this past quarter. So we have U537F, which is the biggest one at 1,781 claims. And then U5233 with 731, U5065 with 233, U537I with 58, and 30993 with 54. And again, some of these will probably look exactly the same, and some of them, there might be one or two that are different from contract to contract. But again, all of these are within both jurisdictions' top 10s. And we also have them out on our website under our top error codes. So with JK, we have, again, U537F with 274 claims, U5233 with 141, U537K, which I think that one's a different one, with 42, U5065 with 27, and 30993 with 10. So, not so bad for an entire quarter's worth of information. Only 10 claims hit that RTP. But let's look at each of these in detail. So the reason code narrative for U537F states that the from date on the notice of admission falls within an existing home health admission period. So just a little background or tip for avoiding this reason code is to verify billing before submitting a new notice of admission for a patient's admission to home health care. Now, this will be assigned correctly on a duplicate NOA for the same admission period. So there should not be a notice of admission already in the system that's either pending processing or already finalized before you submit a new notice of admission for a patient. And a home health agency does not need to submit multiple NOAs for the same admission period. So once the NOA is submitted and the patient remains on care with you, you don't need to submit another NOA for as long as they are with you. That NOA remains active until the patient is discharged or transferred. Now, it's also assigned correctly on NOAs if the provider CCN, the provider number, does not match the CCN on the prior home health episodes or episode admission period that's posted at the common working file. So this has to do with if a new home health agency is trying to open an admission period when there's already one with a different home health agency. So if there is a situation where a patient is being transferred, then the NOA needs to be billed with a condition code 47. And to keep in mind that all transfer protocol must be completed before you submit an NOA with a condition code 47. And the only other circumstance where a condition code 47 would be appropriate would be if you see that there is an open admission period out on the common working file, but it doesn't seem like there's a recent claim out there from the home health agency that opened that admission period. You still need to contact the home health agency that has that patient or that opened that admission period to verify that they either still have the patient on service, and so then you would coordinate a transfer, or that they've discharged the patient but just haven't submitted their final claim showing discharge. And you would have to document all of that information in order to be able to correctly submit a condition code 47 on your NOA. Our next RTP reason code, U5233, says that no Medicare payment can be made because the services fall within a Medicare Advantage enrollment period. So the guideline behind this is, of course, that only original Medicare or a Medicare Advantage plan can be billed for a patient's services. So if the patient is enrolled in a Medicare Advantage plan, original Medicare cannot be billed. So we have to figure out which one should actually be billed. Like if the Medicare Advantage plan, they did have services, or they did have an enrollment in a Medicare Advantage plan, but then they disenrolled from that, and maybe just the common working file wasn't updated yet. That's a possibility, but just make sure that you are verifying the information before billing Medicare. Now, if they start their period of care under Medicare Advantage, but then they switch to original Medicare, you would complete a new OASIS and submit the notice of admission to open the admission period under original Medicare. If the reverse happens, where the patient starts under original Medicare and then switches to Medicare Advantage, you would bill the original Medicare plan only up to the Medicare Advantage enrollment date. And then you would submit your claim with a 06 patient status code. And a lot of times, if you're not aware of that until after the fact, then I believe the system would adjust the claim to show a 06 patient status code. But if you know that the patient is going from original Medicare to Medicare Advantage, then submitting your claim with the patient status code 06 is the best way to go. So again, it's only if you're aware that the patient is going to be enrolled in HMO that you would know to put the 06 on your claim. And again, repeating that to verify the information in the common working file. So looking at Medicare Advantage plan information prior to any care service delivered to the patient and before billing. And you can find those billing guidelines in the claims processing manual. There's a chapter specific to like Medicare Advantage to Original Medicare and then vice versa. Okay, our next reason code U5065 is stating that the from date is prior to the patient's Medicare effective date. And the MBI is the oldest occurrence on the crosswalk. So just a little background or billing guideline here is that only services provided after the patient's effective date can be billed to Medicare. So if their Medicare Part A or B doesn't become effective until a certain date, no dates of service before that can be billed to Medicare. So you want to verify the effective dates for the MBI on the common working file prior to billing. And I believe this is one that may have been assigned based on like the data breaches that caused a lot of MBIs to be reissued. So if a new MBI has been issued for the patient, all claims after the effective date of the new MBI have to be submitted with the new MBI. Now, if there are dates of service that were before the MBI change, you can use the old or the new MBI. And if an MBI has been changed, like after you've already submitted the NOA and after you've already submitted claims, you don't need to adjust those or resubmit those under the new MBI. Those can remain processed the way that they were processed under the old MBI. Now, if you have a span date with a from date that was before the MBI change, so let's say the MBI changed like right in the middle of your billing period, you can use either the old or the new MBI. But dates of service that are entirely on or after the effective date of the date that the MBI changed have to use the new MBI. And then just make sure that whatever MBI is being used, that the OASIS that matches that billing period has the same MBI. So you might need to submit or correct the OASIS with the new MBI. And again, the NOA and any claims processed prior to that do not need to be corrected with the new Medicare number. Okay, reason code U537I states that the from and through dates on the claim fall outside of a home health admission period. So just a little background on the guidelines for billing and how to correct this. That as a reminder, the NOA opens the admission period for the beneficiary. So any dates of service that are provided or any dates of service that reflect services provided to the patient have to follow the date of admission until the patient is discharged. So, there can be no dates of service billed on the claim that are before the date of admission. It's the date of admission going forward. And so you just want to verify the dates that are billed on the claim and the line item dates of service as well that are billed on the claim. And then our U537K says that the home health cancellation, which is it's the NOA cancel, does not match the home health admission period. So if there was information that was submitted on the original NOA, which was that 32A bill type, that need to be corrected. So like the admission date was wrong, or the from or through dates were wrong, or the beneficiary information was wrong, you need to cancel that. But in order to cancel it, you're using the exact same information on the 32D that was submitted on the 32A. And then once the cancel goes through, then you can submit the 32A or the new NOA to show the appropriate information. RTP reason code 30993, the narrative states that the claim has been submitted with an MBI and the MBI hit combination was not found on the MBI cache or the CWF crosswalk. And this is basically saying that the MBI is not valid, like it can't be found. And so what's billed on the NOA or the claim, of course, has to be a valid MBI. And a lot of times this is just because a letter was wrong or a number was wrong or the characters were inverted or mistyped. So just verify that what you're submitting on your billing matches what's in the common working file or what's on the beneficiary's Medicare card. Okay, so I have some resources that I want to go through, talk to you about. And as I said, some of these you may have seen as you were enjoying the rolling slides before the presentation. But I just want to just touch on a couple of things anyway. And while I'm going through this information, I do want to allow you to ask any questions that you have about the information that was covered in this presentation. So I'm going to open up the question box and allow you to ask any questions that you might have about what we've covered so far. And just a reminder, anything that you ask has to be HIPAA compliant. So we cannot have any claim specific or beneficiary specific information as part of the question. It should be just the information that we reviewed in our slides. Okay, and give me just a second. I'm going to open up the question box and I'm going to give you the opportunity to raise your hand if you want to ask a verbal question as well. So, yeah, I'll see your hands raised towards the end of what I'm going through, but you can go ahead and ask your questions in the question box if you'd like to do that. So you just type in your question, click send. I'll be able to see it. If you would like to ask a question verbally, you can raise your hand and I will open up your line once we're finished going through the rest of the slides. So on the next slide, you just see the information about what you can find on our website. So we have the events portion of our website, and that is where you'll be able to find the material that I covered during the session. So if you go to our website and you go to the events page, you know what, I'm just going to drag it over here so you can see it. So I've already navigated out to our events page. So in order to get here, I logged in as a home health or hospice provider, chose a state, and then just clicked on events at the top of the page. And this is where you can see the slides or the slide deck for today. It opens up in a PDF. And so it's that little PDF icon, and that will take you out to the material if you would like to have that for reference or just to look at the information that we covered. I also want to show you, is I think it was also part of that slide, is that we have a lot of information out on our website under Medicare topics and home health billing. And so there's lots of job aids and articles out here that hopefully will help you with any questions that you have about billing the NOA or the period of care claim. So lots of great articles out there for you. I'm going to move that back over. Oh, wait a minute. No, I wanted to show you where our top claim errors are too. So then you can also go to resources and claims and appeals, because I mentioned that there's top claim errors, and then go to top claim errors. And a lot of these that we covered today, you just like type in the claim error, and I don't think you really have to know whether it's a rejection or RTP or even a denial, because I think if you type in the claim error, let's see, what was one of them? Was it U537F that we talked about? Is that one of them? Oh, yeah, there it goes. It comes up here. I just didn't scroll down that far enough. So then you can see, it'll show you that it's an RTP, and you can view the details on it, avoiding correcting this error. So a lot of them that we talked about are out on our top claim errors on our website. So you can go out and look for them there too. On the CMS website, there are lots of resources for you. As far as, of course, the manuals, you want to be familiar with the benefit policy manual, the claims processing manual. Both have chapters specific to home health. There's the Medicare Learning Network and also their Home Health Agency Center page. This is just a little reminder, or a advertisement, if you've not heard, that we have a podcast. Our Navigating Medicare Home Health and Hospice Insights for Provider podcast is released on the second and fourth Thursday of each month. We're taking a little break for the summer, but we will be back soon with new podcast episodes. But there are lots of them out there for you to listen to and to catch up on if you have not listened to any of them, or if you didn't even know that we had a podcast. So we're on Spotify and Apple, and the QR codes will take you out there, but you can also go to our website under the apps. And if you do view all apps, you'll see where the Navigating Home Health and Hospice Insights for Providers is, and then you can click on either Apple or Spotify to take you directly to the podcast from there. We are on YouTube, we are on LinkedIn, we have a way to get messages through what we call Medicare Mobile, our news. We can also play games, and you can text either news or games to 37702 and interact that way. Our Medicare University is our self-service learning portal that is getting a facelift right now. And so if you are signed up for email updates, you've probably seen some information about how that's going through a little bit of a transition, and I think the new platform is going to be available soon, if not already available. It might be the beginning of next month. It's going to launch, like the new look for it. I showed you our website, ngsmedicare.com. Part of that, part of the website is our email update sign up. So make sure that you are signed up for that so you can get updates on like we have new information that's put out on our website, or if we're sending any type of announcements out to our provider community, that's all done through the email updates. And then I've mentioned NGS Connects. That is our free portal for all kinds of information, including looking at your claims. You can also find ADRs and submit documentation through NGS Connects and do all kinds of other things. So it's a great system, and it's free for you. And then, of course, our IVR, which is available 24/7. I think this is one last thing I wanted to talk about before I get to your questions. If you have not heard about our summit, or if you have not been in the past, we do a collaborative summit with the other home health and hospice Medicare administrative contractors. So contrary to what some people might think, like we're not, we don't fight with each other. We actually work together really well, and we like working together. And so we work with them, CGS and Palmetto GBA, in order to put on a collaborative summit. And this year it's going to be at the beginning of October. So it's October 2nd through the 4th. And oh gosh, it's going to be so great. There's going to be so many different areas there from within the contractors. So we're going to have provider outreach and education there, of course, and then we're going to have our appeals department, our audit and reimbursement area, our medical review area, our provider enrollment area, plus we're also going to have presentations by CMS, by the Department of Justice, by the UPIC, which is the Unified Program Integrity Contractor. We will also have the Medicare Advocacy Group there. It's going to be great. So if you can, and it's so cheap for 3 days of education. So If you have not heard about it, or if you haven't looked into it, or if you haven't, asked about going, do that now. It's sold out the last couple years, and we're anticipating it's going to sell out again this year. So, get your registration in while you can, and hopefully we'll see you in October. All right, with that, let me get to your questions. Let's see what type of questions you have for me. Maria was just asking about the PowerPoint and then said, never mind, I see it. That's great. So thank you. But yeah, as a reminder, it is on the events page. So go to the events page and click on the PDF for today's session. And then I do see a hand raise. I'm going to go ahead and open up your line. Looks like Mal, you have a question, and you are self-muted. So if you can unmute, I'll be able to hear you.
Hi, thank you.
Hi, sure.
So I have a claim that I can't seem to figure out how to fix, but it's been RTP because the patient ended up being admitted, and when we did the discharge, it was outside of the 30-day period, which overlapped to a new 30-day period.
Mm-hmm.
And so my question is, when we have a patient who we end up discharging with an O2, but that 30-day period doesn't have any visits in it, do we discharge the prior 30-day, or how does that work?
So I think what you're asking, or what you're saying, is that the patient went to a hospital and they ended up being admitted?
Yes.
Okay, and so instead of waiting to see if they're coming back to home health care, you just want to discharge them, correct?
Not really. So what happened was,
Okay.
we had the patient on services. We have visits scheduled, but the patient kept refusing the visits. And then the next visit was to the new 30-day period. And then she ended up being admitted. And so when we did the discharge, we did discharge transfer to hospital, but because the actual transfer date is into the new 30-day period, it had no billable visits on there. So we couldn't put like one of those location code on there.
Okay, so in the new 30-day period, there weren't actually any home health visits that were done?
No visits at all.
Okay. So then in your first 30-day period that you'd be billing, when they went into the hospital, you could bill up to when they were admitted to the hospital and use that as your discharge date.
Mm-hmm.
If you're going to discharge them. You see what I'm saying? And I know that there's like, I don't run into this that often, so let me look quickly in the claims processing manual, because I know that there's something about inpatient admission.
Yeah, I tried looking in the manual, but for some reason, maybe I'm not looking at the section. I couldn't find my answer, because I know that if they got transferred, the date of the transfer will be the discharge date, and we'll just complete the transfer OASIS. But my only problem is if the 30-day period ended on the 27th and the patient got admitted on August 1st, let's say August 1st, the transfer date would be August 1st, but now it's showing a new claim, a new 30-day period claim for those 2 days,
right?
And there's nothing billed on it. And so I guess I was thinking maybe we should discharge on the last day of that 30-day period. But then if we do that, we can't do the discharge status of the patient transfer, because the actual transfer date is 2 days later.
Right. I'm looking. Yeah, see, the only thing I can see is the coordination with claim episodes with inpatient claim types. And that's basically saying that you can't have a home health home health and inpatient services at the same time. That's the only thing that that section is saying. See, I know that there is something about if the patient like starts a period and then goes to the hospital, and when they come back to home health, they're in a new period, but that's not really the case here. So if you're
It's not, that would be an assumption of care.
all right, if you're specifically talking about like discharging the patient, then you would use like the date that they went into the hospital as your home health discharge date.
Because we try that, and
Mhm.
CMS keeps being claimed because they're saying you need a HIPS code on there with a care location on the claim, and we don't have that because we've never did a visit.
Right.
So now
that's what I'm saying. Like you can only bill periods of care in which visits are provided. So that's why I'm saying if the patient actually went into the hospital like before the second 30-day period began, but didn't get admitted until a couple days later, then your discharge date is the date that they either like the last day that you provided services to them or the date that they went to the hospital, whichever one. Because you're saying that they didn't have any services like toward the end of that one billing period and even into the next billing period. So your through date or your to date would be either the last day that services were provided to that patient or when they like left to go to the hospital and then never came back to home health. Does that make sense?
Okay, so that does make sense. But if we
Okay.
use the last billable date
Mhm.
for that claim, we wouldn't be using a discharge status code saying that it's because the patient had transferred to the hospital. We would be using a different discharge status, right?
That see, I'm as far as like the coding that's on your claim for the patient status code, you would just use like the most appropriate patient status code for that billing period. Because they were still a patient. You know what I mean?
They were just,
yeah.
yeah.
And then they ended up going to the hospital.
Yeah, they kept refusing, and then by the time we were able to call and actually get something scheduled, they were admitted at the hospital. So
yeah,
I guess in this scenario, that it sounds like it's probably more appropriate for the last billable date and then discharge as patient review further care. Yeah.
It seems like for your situation, it would be it would seem like most logical to use the last date that they receive services at your agency.
Okay, makes sense. Thank you.
You're welcome. All right, I'm going to go ahead and remute your line, and then Michelle, I see that you have your hand raised, so I'm going to go ahead and unmute your line, and if you unmute yourself, you should have your line open. Oh, Michelle said no problem. All right, never mind. All set. Okay. Oh, next question. This is actually a good question from Alexa. Will there be a link for us to replay this? Actually, that brings me to the fact that we do put all of our recorded sessions from what we've done each month on YouTube. So if you go out to, and it's not going to, this one isn't actually going to be posted until, let's see, we're at the end of July, so it actually should be posted pretty soon because we usually do it within the first week of the next month, excuse me. And if you go out to our YouTube channel, it's under, hold on, let me go out there and then I can show you. Okay, so if you go out to our YouTube channel, I'm going to move this back over here. So I just went to, let me show you this part. I just went to our apps and then I did view all apps and then I clicked on YouTube and then it takes me to an external page where it opens YouTube. And if you go to the YouTube channel and you go to playlists, you will see there are home health, like there's a home health billing series that's out there. And then there's also a link for home health educational videos. And I think those are getting like in the process of getting updated. But what you're talking about is our on-demand videos. So all of the educational sessions that we do within a month are then posted to our on-demand videos for playback. So you can see a list of on-demand videos. Sorry, that started playing right away. So we have, we still have the home health top claim errors. Ignore these. These are from April. So I'll have these replaced with the one from today, but it will be out on our on-demand videos. So good question, Alexa. Thank you for asking that. Okay. Any other questions? We had lots of good ones and we used up a good amount of time. One thing I want to remind you, if I don't see any other questions popping in or hands raised, is that I didn't get a link for a survey for today's session in our chat, but you will be receiving one in email. So once we're finished with this session, you'll get an email that's asking you to take a survey. I would love to hear your feedback about the session today and like what we can do well and what we can improve on, like what we do well, what we can improve on. And so, yeah, I would just love to hear your feedback. And I don't think, shoot, did I have my screen paused when I showed you that? Here is where just in case, I think I had my screen paused. I'm sorry about that. So you didn't even see what I was doing. So I went out to, and if I didn't, I am so sorry. It's late in the day for me. But to get out to YouTube, I went to apps and then I clicked on YouTube because you have to expand them all. You have to do view all apps to see all of this. And then it takes you out to YouTube where you can see the on-demand videos, and the playlist is here. So, sorry, here, the on-demand videos. You can see the playlist there. And no, I don't want to pay for YouTube. So anyway, that's where that is. I'm sorry if I was talking through all of that and you couldn't even see it. So anyway, I don't see any other questions coming in, but you had some great ones, and I thank you so much for joining me today. Just if you could remember, take a couple moments to complete the survey. I would love to hear your feedback, and we'll do this again soon. So sign up for our upcoming events, and I hope you all have a wonderful rest of your day. Thanks again for joining me. Take care, everyone. Bye.